anchor. It's not absorbable. It's a permanent material. So the anchors are never going to be dissolved. And that was one of the reasons why we were interested in studying pain as an outcome, to ensure that there wasn't going to be an increase in pain with the device. And we certainly have seen that there is, we've not had any patients with intractable long-term pain. So in conclusion, I love to use Anchorsure, specifically using the anterior approach to hysteropexy, where the dissection is much smaller than when we approach the ligament through a posterior approach. Having a small profile instrument is beneficial in this circumstance. We find that there's a very
the difficulty in retrieving the anchor. And I've never really found the anchor to be the problem. It's really about the amount of tissue that's involved and trapped or incorporated in some sort of, in strangulation or ischemic change, right? So what's beautiful about this device, if your anchor is someplace you don't want it to be, you just pull the suture away, the anchor just floats up into never, never land. There's no traction on that anchor. It has such a small footprint, it's not really going to do any damage in of itself by its sheer presence. So you don't have to go fish the anchor out. For 30 years, I've dug out a lot of people's sutures that were placed and caused retractable pain. I've never had to go after an anchor. Just haven't never had to dig an anchor out.
This slide shows the profile of the anchor when compared to Capio or Capio-like devices. It is important to know that it's not just the profile which is of importance, but it's the tactile minimal dissection needed to apply the anchor compared to visualization of the sacrospinous ligament needed for freehand suturing or placement of a Capio device. My clinical experience to date, I've performed over 1,000 repairs utilizing Anchorsure with over 3,000 anchor placements. We've had no intraoperative or immediate postoperative complications directly related to the anchor.